A very good afternoon to one and all present here. It gives me immense pleasure to welcome you all to the World Multiple Sclerosis Day Symposium. Without further ado, allow me to introduce to you Professor Dr. Satish Kadilkar, the moderator for today's session. Dr. Satish Kadilkar, sir, is the Dean and Medical Faculty and the head of Department of Neurology at the Bombay Hospital Institute of Medical Sciences, Mumbai. He is the convener, neuromuscular subsection of IAN, trustee and secretary of the Muscular Dystrophy Society of Mumbai, fellow of Royal College of Physicians, London, fellow of National Academy of Medical Sciences, fellow of Indian Academy of Neurology, and fellow of Indian College of Physicians. His area of interest include multiple sclerosis, stroke, neuropathy, and muscular dystrophy. Professor Dr. Satish Kadilkar has over 7 books, 57 book chapters, and over 250 publications in national and international peer-reviewed journals. He is awarded the Best Teachers Award at GMC and JJH. Thank you, sir. We welcome you to our podium today.
Good evening. Thank you very much for the kind words. Let me welcome everyone to this World MS Day. We have got 3 stellar faculties here, and the program that we have today, please can everyone mute themselves? Yeah. The program what we have today is we will have 3 lectures which look at 3 contemporary aspects of multiple sclerosis, and then we will have a discussion. Questions and answers will follow after all the 3 lectures, and I will request you to put your questions in the chat box, but please don't put any questions pertaining to one's own illness. That can't be tackled on this forum. Now, as you know, multiple sclerosis is really very much here, and we are recognizing it more and more sufferers are there in India. And therefore, it is very important that on this particular day, we have this symposium. And if I could have the first speaker's biodata, please. Yes. Our first speaker today, as I told you, today we have 3 absolutely stellar experts. The first speaker is Dr. Netravathi, who is professor in the Department of Neurology at the most reputed National Institute of Medical Sciences and Neuroscience, Eminence, Bangalore, India. This institute is one of the nation's pride, and in such an institute, she is doing very, very good work. And her areas of interest are, of course, demyelinating diseases like MS, NMO, the newer ones, MOG, immunological diseases, neuroinfections, on which demands has a lot of work, and leukodystrophies. As you can see on the biodata, she has got close to 100 publications and many book chapters, and has been awarded 2nd best paper presentation at AOCN and in 2014 for the clinical, radiological, electrophysiological, and characterization of post-trauma movement disorders. So let us welcome you, Dr. Netravathi. Thank you very much for being here, and do tell us about the current concepts. Yeah. So maybe we can take this presentation off, and Dr. Netravathi will present hers.
A very good evening to everyone. Thank you, sir, for such a nice introduction. So in this week where we are all observing the World MS Day, it's very apt that we realize the importance as to why we need to understand few concepts. A lot of research is being done, and a lot of newer medications are available. In just last 10 years itself, every year we are seeing almost large basket full of medications which are coming up in the treatment of multiple sclerosis. And many of these are making patients' life better. So once we know that these medications are going to be doing good, we'll be able to understand how to tackle this illness only when we know where is the problem actually lying. What is a pathology where it is lying? And that is what I'm going to discuss about in the next few minutes. Sorry, the next few minutes. So multiple sclerosis, as we all know, is of multiple types. Most common type is the RRMS, which is 80 to 90% of them, followed by the secondary progressive form. And this usually happens whenever patients have not been treated or they continue to have relapses or the treatment is delayed when they go into the progressive form of illness. And there are less than 10 to 15% of them where the progressive illness starts at the beginning itself. And this is called as the primary progressive multiple sclerosis. Why I'm trying to bring about this spectrum of MS is because though MS is one disease, you can see that it can start with RRMS and that patient can evolve into SPMS, or a patient can just start off with primary progressive. So basically we have a relapsing form and you have an inflammatory form and you have a progressive form. Why these two spectrums are there? So to understand this, we need to understand the pathophysiology of this MS. So why does it occur? So MS is not a genetically mediated disease. That is, it is not passed on from generations. So why does a person develop MS? So basically, a person should have a genetic susceptibility. Because of this genetic susceptibility, he has an immune system, or he or she has an immune system which is dysregulated. And whenever there is some antigen which is exposed, which could be some virus, or it could be some drugs, or it could be something which we do not know. So this can trigger a dysregulated immune system and then evolve into multiple sclerosis, and the inflammatory phase starts. So if you see, this is a picture of the neuron. This orange is the axon, and then you can see that there is a long sheet wire-like thing which is the axon, and it is being covered, these blue coverings which are called as the myelin. And we all know this destruction of myelin is basically the reason why we develop multiple sclerosis. So let me just go through a simplified model to understand as to what happens basically in MS. So what happens is some foreign exposure happens. Let us take it could be a virus which has come to the body. So usually what happens, like whenever you develop a flu, like even the COVID which happened, your body tries to fight it out. Your body tries to mount an immune response and tries to fight it out by gearing up your immune system to fight against the virus. At the same time, what happens, instead of just fighting against the virus, it also starts acting against its own cell, that is his own body itself, which is called as a dysregulated immune response. And that starts with these immune cells, which we call it as T helper cells. And then once this inflammation sets in, they want to go and attack the CNS. That is, they try to break the blood-brain barrier which is there. So this blood-brain barrier is a protective covering which is there, because of which not all infections can just go away into the brain. So this is disrupted, and eventually these cells reach into the central nervous system. Central nervous system, I mean here, is the brain and the spinal cord. So where the further inflammation sets in, and then there is further destruction of myelin. So let me show you. So this, you can see these blue ones are the ones, this is the normal myelin which is there. But as you can see here, it's eaten out, and these are eaten up by the macrophages. They're the eating cells, they're the scavenger cells which are present in our body. So you can see here, it started with just not false recognition, I would say, a false recognition of an antigen which the body took it and eventually started mounting a response against their own body. And then eventually there is demyelination, which results in multiple sclerosis. So this is a simplified model. So let us go more details into what happens in this. So there are two theories which are put forward. One is the outside-in theory and the other one is the inside-out model. So let me explain. So basically in the outside-in theory means there is some antigen which is exposed in the periphery. That is, it may be either at the skin level, at a GI system level, or at a pulmonary lung level, Then it goes to the lymph nodes, the draining lymph nodes, and then there is this immune dysregulation cells where the inflammation mounts, and then that crosses into the brain and then damages the myelin. So this is the outside in. That is from the outside, periphery. It is going into the brain and attacking the nerve cell. Whereas the other theory says about the inside out theory. Here what happens is, as you told you, these are the oligodendrocytes. These are actually the supporting cells for our axons and neurons. So then some pathology starts happening in the oligodendrocytes, which we call it as apoptosis in our medical term. So this results in a lot of inflammation. And then these inflammatory cells go to the periphery. These are recognized as foreign. And then there is the inflammation which is set up. And that again goes back to the brain and then starts attacking. So the problem starts in the CNS, goes to the periphery, further gets emphasized, and then again goes back to the brain and gets demyelination. So these are the two theories which are present. So basically, whenever we identify demyelination, what do you say? That there is some scar, there is a white spot which is there in the brain of a person. So which is called as demyelination. Demyelination means the myelin loss, which is recognized as a plaque, which is recognized as a loss of myelin. Along with that, you can have astrocytes. Astrocytes are the supporting cells which are present across the axons and the nerves. They also get started attacked. And this all happens on the background of inflammation. I'm going on stressing on this part of inflammation as to why I will be eventually telling. So you have a demyelination, scarring of the astrocytes, and inflammation, all these three which happens in this pathology. So initially we thought it is only in the white matter, but now we know it's not just the white matter, even the gray matter is affected. And it affects even the deep brain stem and the spinal cord. And this is the place where the high morbidity can be there. It is not just affecting the myelin, even the supporting cells are affected, axonal loss happens, neuronal injury will be there. So if you take this is just an illustration to show. So the active lesion actually starts, this is a central vein which is there. So the lesions actually start over here. So you can see there are a lot of red dots. These are called as CD8 cells. And then very closely you look around this, you see a lot of small green and blue dots. These are the CD20 positive B cells and plasma cells. So basically these are the inflammatory cells. So CD8 cells are maximum, followed by CD20 and then few plasma cells. So it starts with this inflammation, which starts across the central vein, and then eventually the inflammation starts. So the focal white matter, that is a plaque, we can grade them based on different types, whether they're active or a chronic type. So there's a classification which has been given. So the most common, especially in the active lesions, is the pattern 2, which is nearly in 60% of the patients, where you have demyelination and the antibody mediated, the classical one which we all know about. Then you have the pattern 3, which is present in nearly 26% of patients with MS. So here what happens is, it is oligodendrocyte, that is the supporting cells which are most affected, along with demyelination. And then you have the pattern 1, which is followed by in 15% of the patients. Here, sometimes it is thought that whether this is toxin induced. So you have lot of, apart from demyelination, you have lot of immunoglobulins and complement also being deposited. And the last one is the pattern 4, seen in less than 1% of the patients. So these are the different active type of white matter lesions, plaque can be there. And whatever I mentioned, all this will be more in SPMS compared to PPMS. So now this was about the white matter pathology. There is something called as a degenerative side of MS. So basically this happens, as I said, the oligodendrocyte. These are the supporting cells which are there. So they actually support the axons and the neurons. So we find that there is a lot of elevated myelin basic protein and MAG. MAG is myelin associated glycoprotein. So this is present in the innermost layer of the oligodendrocyte, the innermost layer of the myelin. So because these levels have been increased, so there is one postulate as to where till now we've always been thinking that it's a loss of myelin which is causing the demyelination. But is it so? Is it that these myelin, which are supported by the oligodendrocytes, they are affected and that is causing the reverse affection of the myelin. This is one of the theories which has been put forth to see whether this is because of the degeneration. Because apart from the oligodendrocytes, there is also axonal pathology. So like what I said, the oligodendrocytes, which are the supporting cells, they're actually supporting the neurons. So when these oligodendrocytes start shrinking, there is nothing support being given to the neuron. So what happens is there is something like as if the nourishment is taken away, and then this oligodendrocyte neuronal crosstalk, which actually happens for stability, is disrupted. And then this eventually leads to axonal involvement. So inflammatory cells, CD8 cells, also cause axonal injury, and this could be either antibody or complement mediated. So degeneration basically happens because of oligodendrocyte and axonal injury, which happens in multiple sclerosis. So inflammation, which is the most important part of MS, especially in the early stages, causes a lot of microglia activation. So if you remember the initial diagram where I showed, there were some macrophages which are just eating up of the cells. These are also part of the microglia which can be there. So these are all starts getting activated and they start infiltrating. And it is not just at the white matter lesion. So when we look at the MRI, we see that there are these white spots in the brain which are there at different areas. So we know that this is the abnormality. But we now know that those places where actually even the normal appearing white matter and gray matter is also there also all this inflammation can be set in. And these are also involved. It is just that it is not seen on the MRI and the person is not symptomatic. So normally appearing white matter and gray matter also can be affected. And as I said, the most important is the CD8 positive T cells. And it was one of the landmark discovery of the usage or the beneficial effect of monoclonal antibodies, because of which we know that the CD4 cells are the major drivers. That is, though we know, like when I showed you this picture, I said that most of them are red. These are the CD8. Though these green ones, which are CD4 positive cells or CD20 cells, these are very less, but they are the ones which initially starts. Eventually, it progresses to CD20 and CD8 take over in the inflammatory phase.
Thank you.
Thank you. Because this inflammation is there, what happens is there is a release of a substance like the oligoclonal bands which we take. And this is very important because the release of this, we know this is used in the diagnostic criteria of multiple sclerosis. So this is all because of inflammatory phase which is there in MS. This is again the diagrammatic representation showing the different inflammatory phases which are there. So basically what I want to tell is that one of the level would be at the meninges level, the other would be at the worker organ spaces. So for the people to understand what are these is, so this is just the brain which I've just taken a cross section. So you have a covering across the brain, which you call it as a meninges. There you can have these immune cells, the inflammatory cells sitting, and there they can form follicles. Or in the worker organ spaces, VR spaces, they are actually space in between few neurons which are there. So there also these inflammatory cells can be sitting. So these are the different types of places where these inflammatory cells can be present and eventually lead to edema, eventually lead to demyelination, and eventually worsen the lesions. So all this, what I was talking about was inflammation and the white matter. So we also know now that it's not just restricted to the white matter, even the gray matter can be involved. So now whenever we do the MRI, we may be able to appreciate the gray matter involvement, telling that there is an atrophy, there is involvement. Or sometimes when we do a special sequences like the DIR sequences, we may be able to appreciate few of the gray matter involvement, or on 7 Tesla on animal models, we'll be able to appreciate the gray matter. But remember, it is just 10 to 15%. The same brain, you do a post-mortem analysis, you see that nearly 90% of the gray matter is involved. So it is not just a pure white matter disease, but also both gray and white matter. So these are the different types of gray matter involvement. So the most common is the subpial involvement, type 3. This is followed by subcortical, type 1. And then you have the intracortical. So these are the 3 different types which are there. And subpile lesions are most abundant. But remember, these are not picked up on the MRI. These are only picked up when you do a pathological evaluation. And on animal studies, it has been picked up. So these are the places where you have a lot of these follicles or a lot of these inflammatory cells which are present. And these are more abundant in secondary progressive form. And you may not find at all in the primary progressive multiple sclerosis. So all these inflammations which is there, they produce a factor which eventually causes a lot of demyelination and microglia activation. So this, as I said, can happen both in the normal appearing white matter as well as gray matter. So now when I tell that nearly 90% of the gray matter is affected, so is it really a white matter disease or is it a gray matter disease? Some people think that maybe it's a gray matter disease which is not being picked up. So it is just a secondary Wallerian degeneration which is being picked up as a white matter plaque. That is being explained by this difference is in the pathological evaluation as well as the MRI which is present. So now a few of the things which are emerging are, one is the mitochondrial dysfunction which can be there. And this is mainly because we are seeing now that there are many neurodegenerative disorders where we are finding that there is a mitochondrial dysfunction. And this again, same lot of pathology can be there. This could be because of reactive oxygen species or because of just a mitochondrial dysfunction. So this may not be causing primarily, it may just be a subservient along with the other processes which can be there. And gut microbiome and MS is evolving rapidly to understand. So because this is because of the involvement of the diet and the environment. And many of these patients are on immunomodulators, whether these are all disrupting the gut microbiome and worsening the MS. That is a reason there is a lot of research being done on fecal transplantation. So finally, the pathogenic implications of whatever I have told is basically what we need to understand is, though initially I started telling that there is a relapsing form, a progressive form, in the pathology, it is not the quality, it's a quantitative difference which is there between the relapsing and the progressive forms. And the inflammation is the most important, and there are two types which can be there. And predominantly, it is a CD8 positive T cells which are there, followed by CD20 T cells. And that is the reason of the efficacy of the monoclonal antibodies. So I just want to stress upon this diagram. So this orange line is the one which says that there is an inflammation, which is going up initially and then comes down. And if you see this, if you follow this green line, this is the axonal loss which happens, which just keeps on increasing exponentially. So let us try to catch our patients early here where there is inflammation. So if you catch these patients early in inflammatory time, you'll be able to see that many of these symptoms are minimized, as well as you may be able to either prevent or halt or prepone or postpone the onset of the progressive form. So all of us know that time is brain and stroke, but let us remember it is so in MS also. So that is the reason we need to understand this pathophysiology so that we catch these patients early where all these problems are setting in. If we address it early, you may not even reach the higher spectrum of the illness. So that is the reason we need to understand this. So finally, I've tried to summarize the pathogenesis in most of the slides. So I'm thankful to the team started at Eminence with the MS clinic, which runs for Saturday of the month. And we have now a very nice team of multidisciplinary people which are involved in the care of MS at our institute. Thank you.
Thank you. Thank you very much, Dr. Netravathi, for this beautiful and very lucid talk about how it starts as inflammation and then how degeneration comes in. I think you made some very important points, and we'll take them in the questions and answers towards the end. So again, thank you very much. And we also welcome Dr. Deepak Arjundas, who wasn't there when I introduced. Deepak, welcome. Happy that you're on the program.
I'm sorry, I'm translating between two places.
Yeah, that's what I was told. But thanks for still finding the time to be here.
A pleasure to be here.
So we go to the second presentation that is on disease-modifying treatments in MS, another very important area, and that will be covered by Dr. Shruti Nair. who is Associate Professor of Neurology, again at the very prestigious institute of Sri Chitra Tirunal Institute of Neurology, where she looks after two subsections, multiple sclerosis and neuromuscular disorders, and produces a lot of original work there. And she's also a member of the Kerala State Technical Committee for Multiple Sclerosis. And the areas of interest are MS and related disorders, neuromuscular disorders, and electromyography. She's more than 45 peer-reviewed publications and chapters. And as you can see, she's won many awards. She's a recipient of fellowship scholarship from the North American chapter of International Federation of Clinical Neurophysiology 2 years ago, and Young Neurologist Award at the 9th World Stroke Congress 2014. MS International Federation, the Dupree Grant, which is a very important grant in MS in 2019. So, Dr. Nair, welcome. Thanks for coming for today's program. And do tell us about the disease-modifying therapies in MS, which everyone is eager to know. They are growing by leaps and bounds. Dr. Nair.
Thank you very much, sir, for the introduction and for inviting me to this very important program. It's an honor and pleasure to be here with sharing the stage with so many of the stalwarts in MS field. So I'll be speaking on the disease-modifying therapies in MS. Dr. Netravathi has very brilliantly illustrated why it is important to start therapy quite early in MS and how it can modify the natural history of MS. So just to start with, when we discuss about white matter diseases of CNS, we know there are genetic diseases and acquired diseases. Genetic diseases are ones which we hear of are leukodystrophies. The acquired diseases, there are primary demyelinations, which means that they are idiopathic or immune mediated. And there are secondary, which are caused by some nutritional deficiencies, infections, etc. But among the primary demyelinating disorders, MS has a very special place. Considering the other ones like NMO spectrum disorders, Morg antibody, etc. It is not just the most common type of primary demyelinating disorder. It is a very recent that it is not just an inflammatory disease. So in all other conditions, patients have problems only when there are active relapses or active inflammation going on. In MS, there is always inflammation. And in addition, unfortunately, we also have a neurodegeneration, which Dr. Netravathi has very clearly illustrated. Now, when we talk about treatment of MS, there are then two major aspects to be tackled. One is the inflammatory part, which are clinically characterized by relapses, and MRI, which shows new lesions or active lesions. And there is another part when the patient is not having any active acute relapse. So acute relapse looks like a stroke. There is an acute worsening and then the patient improves. That aspect is not there, but the patient is going on worsening over time. Currently, what we have as therapy for MS are divided into three. There is a therapy when the patient has an acute relapse, and that is usually by corticosteroids. Very few patients sometimes require plasma exchange or IV immunoglobulin. We, of course, give symptomatic therapy based on whatever residual problems that they have, like for bladder problems, spasticity, etc. But I would say the cornerstone of therapy in MS is a disease-modifying therapy, which tackles the occurrence of relapses per se. So, unfortunately, as of now, our search for a remyelinating or a neuroregenerative therapy have not been very fruitful, although very recently we have had a few drugs which could also tackle the progressive part of MS. Now, what are these disease-modifying therapies? These are basically immunomodulated drugs which predominantly act on the adaptive immune system. Which predominantly act on the adaptive immune system, may also act partially on the innate immune system. They tackle the acute inflammatory activity in the sense that they are most active in patients who have ongoing relapses. Now, compared to the general immunotherapy which we commonly use, like azathioprine or steroid or mycophenolate mofetil, these are also to some extent mildly effective in MS. But these diseases tend to be more focused on the MS pathophysiology, and they have fewer cumulative toxicities, especially the lower or the moderate efficacy medicines tend to have fewer cumulative toxicities. But they may also have a propensity to worsen conditions which mimic MS like NMO. Now, Sir Stilling, there are currently a very large number of disease-modifying therapies in MS. So why do we need, or what happens in MS when there is no treatment? Dr. Netravathi had already shown this. You can see that in about 85% of patients, we have what is known as relapsing remitting MS, which means that patients have repeated attacks of some neurological deficit, depending upon where the demyelinations occur. Sometimes it is optic neuritis, sometimes it is myelopathy, sometimes it is cerebellar dysfunction. So they have an acute deficit from which, with or without treatment, they may come back to either baseline or just may have some incomplete recovery. And you can also see the arrows over here, which shows that much more than the clinical attacks which are seen here, you also have MRI attacks, which are new lesions getting accrued in the MRI. Over time, in a patient who is untreated, they go into what is known as a slow progressive phase, which is referred to as secondary progressive MS. So in an untreated patient, by about 50% of these untreated patients would translated to secondary progressive MS by about 20 years of having their illness. And they may or may not have overlapping relapses on top of secondary progression. And if you think disability-wise, by 15 years, half of the patients who have relapsing remitting MS will require a one-stick support to walk. And this, you have to keep in mind that MS patients have their illness starting either in the adolescent period or when they are quite young, between 50 to 35 years. So that is the burden of this disease if it is untreated. It has also been shown in older studies that if the number of relapses increase, there is also an increase in the chance of having a disability. So when there is high disease activity, there is more rapid accrual of disability. Although, as you know, that it is not just a relapse which determines the disability, progression also has a major role. But however, more relapses may translate into a faster progression. Now, MS was identified far in the 1400s. It was initially described as described, but the entity itself was identified only in 1870s when Dr. Charcot described it clearly and gave it the name of disseminated sclerosis. But you can see that from that till 1993, we never had any particular specific therapy for MS. By 1950s, it was understood that this is some kind of immunomodulatory therapy may work in MS, and people started using corticosteroids and other non-immunosuppressive drugs at the time, but they were found to be not very useful in preventing MS relapses. But then in 1993, the first specific medicine came, which was the Interferon. And from 93 onwards, till 2008, we had a slow trickle of new drugs coming. And in the last 10 years or so, we have had it's like a rainfall. There has been a large number of newer immunomodulatory therapies which have come up, which are specific for MS. And now at this point, we are spoiled for choices. So it is important to understand what are those disease-modifying therapies and how exactly they work in MS. So these are the different disease-modifying therapies. It is bewildering kind of looking at them. So it is easier to try to see them from the way they evolved over time. So the initial ones which came up are the injectables, those which are taken like insulin medications. And then we had the oral medications. And currently we have many monoclonal antibodies which have come up, and some of the more cytotoxic medications which are also found to be very useful in MS. So as I mentioned, the first drug which was identified for use in MS was Interferon. There was Interferon beta 1b was the initial one which was shown to be effective in a randomized controlled trial when they compared it along with aside a placebo. And along with Interferon, in 1996, another non-interferon medicine, that is a glatiramer acetate. This is a polypeptide compound. This was also identified. Both of these specific acted by a pleiotropic method, because there are multiple methods of actions. They converted a pro-inflammatory milieu, which is seen in MS, into an anti-inflammatory milieu. They restored the normal T-cell regulatory activity and promoted the blood-brain integrity in case of Interferon and the remyelination in case of glatiramer. So interferons, although they are just called as a single group, there are at least 4 different compounds which are understood. You have interferon beta 1b, 1a, which can be given intramuscularly or subcutaneously. And more recently, in 2014, we have a pegylated interferon beta 1a, which has the same efficacy, but has the advantage of lasting for longer. So these medications have to be taken as injection. For betaferon and Rebif, it has to be taken thrice a week. Whereas for Avonex and Plegridy, they have to be taken once in a week or twice in a month. Glatiramer is given as a subcutaneous injection every 20 milligram every day. The interferons, the major problem with them was the flu-like symptoms which most of the patients do experience. And they are usually very much fatigued after taking the injection, so that there is a lot of injection fatigue which happens from interferon. Glatiramer, on the other hand, though it is taken as a daily injection, very uncommonly produces any systemic problems, but they produce local site reactions very commonly. Now, if you see that in most of the studies, what they have looked for is for the absolute risk reduction, which means the annualized relapse reduction, how much occurs for a given compound compared to the placebo. And for interferons and glatiramer acetate, this was around 30%, which means that over 1 year, the chance of it reduces the risk of a relapse by 30%. Now, this was much better compared to the options which were there at that time. But in 2004, there was a new magic drug which came up. This was a monoclonal antibody, which is called Natalizumab. What Natalizumab does is it prevents the entry of the inflammatory cells into the brain by blocking the receptors which are responsible for it. So there is no inflammatory activity happening within the brain. And this drug was such a big important thing at the time, because we can see the reduction in the attack rate, which was 68% compared to the approximately 30% that interferons and glatiramer had at the time. So this had to be given as an infusion every month, 300 milligram to be given every 4 weeks. And it was relatively well tolerated. But this was all going fine till 1 year later, when there was reports of viral illness called as progressive multifocal leukoencephalopathy. And this is one, PML is one condition which is caused by an opportunistic virus known as JC virus. And we have heard that in the context of HIV. It was shown that Natalizumab can produce an increased risk of PML. And for that reason, the drug was withdrawn from the market for 1 year and then reintroduced with a black box warning and with the program to very closely monitor it. So now we have understood that Natalizumab is a great drug. It is well tolerated by the patient, but in all patients, we have to use it with an understanding of the risk of the patient developing PML. So there are 3 factors to be considered while deciding the risk of PML. Whether the patient has had an exposure to JCV, that is JCV antibody status, how long Natalizumab has been used. So if it is more than 2 years, there is an increased risk of having an infection, and whether the patient had ever previously used immunosuppressive therapy. So considering all these 3, we can make an algorithm and decide whether the patient is a good candidate to receive Natalizumab or not. So for a long time, these were the options which we had. Now, by the beginning of 2010s, we started having a lot of oral therapies, of which 3 survived the onslaught of multiple trials, RCTs. 3 of them have come into routine use. So one is Terraflonamide. So Terraflonamide is, you may know leflunomide, which is used in rheumatoid arthritis. This is a congener of that. It also inhibits the pyrimidine metabolism, and by that reduces the activity of lymphocytes. It is almost similar in its efficacy to the interferons, about 30% or so. The side effects are not very high. They produce hair loss, some lymphopenia. Some may have a severe liver disease. But the major problem which it had, or at that point was considered a major problem, was teratogenicity. It is given as a single oral dose, usually around 14 milligram per day. there was a stronger medicine was a dimethyl fumarate, which is another drug which had pleiotropic mechanism of action. It acted through a specific receptor called NRF2 and induced anti-inflammatory effect both in the peripheral immune system as well as in the central nervous system. So this was a relatively very safe drug to use. The major problems which we usually encounter is only gastric problem. And in the RCTs, it showed an improvement of 50 to 60% reduction in the attack rate compared to the placebo. And the strongest among the oral agents was fingolimod, which belongs to a group of drugs known as sphingosine 1-phosphate receptor modulators. It acts somewhat similar to natalizumab. So natalizumab prevents the entry of lymphocytes into the brain, whereas these sequester the lymphocytes within the spleen or the peripheral lymph node organs. But unlike the medicines which we were talking about earlier, this comes with a lot of side effects. There is a risk of bradycardia when it is given initially. There is a risk of macular edema, which has to be monitored over time. And there is a higher risk of herpes infections, including herpes encephalitis. There is a risk of varicella zoster infection as well as PML. So this is one drug which needs to be very closely monitored. But in observational studies, it has been shown to be more effective than DMF, and it is given as a single daily dose. More interestingly, there are other S1P modulators which have come. Of which siponimod has been already approved in India, but has not come yet. Why siponimod is important is because it has some efficacy on progression as well, and it is the only drug currently approved for secondary progressive MS. Ozanimod and ponesimod has not yet arrived in India. Now we come to the other monoclonal antibodies other than natalizumab. The most important ones are the anti-CD20 antibodies. So we have very commonly used one is Retoxamab in our country. It is an off-label drug because we don't have RCTs which were powered to look at its efficacy, although there were many studies open label as well as the phase 2 studies which were done in Retoxamab. It has a very high efficacy, somewhere in the range of 85 to 90% in preventing relapses. But it requires the patient to be screened properly for hepatitis infection as well as tuberculosis, as well as other bacterial infections. It is given as an infusion, 1000 milligram or 2 gram at the beginning, followed by every 6 months of 500 milligram to 1000 milligram infusion. The other medicines which are anti-CD20 therapies are ocrelizumab and ofatumumab. Ocrelizumab is well studied, is also given as 6 monthly infusions, but it's not been marketed in India yet. It's likely to come by next year. Ofatumumab is different from the other two medicines in the sense that it is given subcutaneously. So the patient does not need to get admitted. Every month, the patient has to take this as a subcutaneous injection, and the risk of infections are also lower compared to rituximab and ocrelizumab. And this has already again been licensed in India, but will probably come into market in 1 or 2 months. Now, the last group of medicines are the immune reconstitution therapy. So what we mean by that is there are 2 ways we can give DMTs, either as a maintenance therapy or as a single shot, which completely annihilates the immune system, and then the patient may develop a normal immune system in its aftermath. So there are 2 main drugs which are licensed. One is alemtuzumab, another is cladribine. So alemtuzumab acts on CD52 antibodies. As you know, it is a monoclonal antibody. So it targets CD52 and completely wipes out T cells and B cells in circulation. It has to be given 5 injections in the first year and 3 injections in the second year, and that is the end of the therapy. And that is almost a cure for MS. But the problem with alemtuzumab is that the risk of infections is very high. About 95% have some kind of infusion reaction or some major side effects. And about 30%, up to 20 to 30% may have a serious adverse effect, particularly infections. They can get secondary autoimmune disorders, particularly thyroiditis and immune thrombocytopenia purpura. We also have found vascular diseases as an aftermath of alemtuzumab injection. Cladribine is an oral agent which can be given as a IRT, and this is a selective blocker of lymphocyte DNA synthesis. This is also given for 2 years or 4 years. It is given as as tablets, which can be given 4 to 5 days a month for 2 months. This also has a significant risk of side effects, but not to the extent of Alemtuzumab. There is a risk of lymphopenia, upper respiratory infections, and some increased risk of tumors as well. And finally, a small word on stem cell transplantation. So MS is one of the conditions where a bone marrow transplantation, it should be done as a proper bone marrow transplantation the way it is done for malignancies. This is found to be very, very effective in MS. But the main problem is that this comes with the risk of mortality. The previous studies had shown up to 5% risk of mortality, but with newer techniques of giving the ablative therapy. So the reason for the mortality is that you wipe out the immune system using a chemotherapy, and that wiping out leaves the patient at risk for many infections. By changing the chemotherapy regimen, they were able to bring down the risk of mortality to approximately 1% in the recent studies. But as of now, this is not approved for MS therapy. The cytotoxic drugs cyclophosphamide and mitoxantrone were also used as immune reconstitution therapies previously, but they have a high risk of toxicity, particularly bone marrow toxicity, risk of infections and malignancies. So we do not prefer them at present. So now we have seen that there are so many DMTs which are available. Some of them have pleiotropic, that is multiple mechanisms of action, and dimethyl fumarate. Some act by producing the reducing proliferation at the level of DNA, which include terraflonamide and cladribine and the cytotoxic medications. There are some which completely deplete certain adaptive immunity cells like Alemtuzumab, which depletes both T cells and B cells, anti-CD20, which depletes B cells, and you have certain drugs which prevent the migration of cells into the brain or out of the immune orbits. When you see, we can see that this is the chart which shows the patients who have attained no evidence of disease activity, which means that there is no clinical or radiological evidence of MS activity for 2 years. We can see that the interferons have a very low chance of achieving that, whereas the Alemtuzumab, Natalizumab, and cladribine, they have a quite high, as well as the anti-CD20, they have an increased chance of the patient attaining a NIDA. And finally, the best response is to hematopoietic stem cell transplantation, which comes with a lot of risk. So those medicines which are not highly effective are now grouped as platform therapies. They are moderately efficacious, which include interferons, glatiramer, and the 2 oral agents, terraflonamide and dimethyl fumarate. Among the highly active agents, the first lines would be fingolimod and natalizumab, and more highly active ones are the anti-CD20 agents, alemtuzumab and cladribine. So recent studies have shown that compared to patients who have never been treated with disease-modifying agents, there is the chance those who have been treated completely with the disease, that is a fully adherent to disease-modifying therapies. Those patients who were never treated had a far higher risk of having an earlier chance of having difficulty in walking. But this is, you have to understand, there is a risk of progression increases with age, and the DMTs are most useful when they are given in the earlier phases of MS. So we say that there is a window of opportunity during which the therapies are effective. So when at the time when the presentation of MS occurs, which is known as clinically isolated syndrome, to the point when it becomes a late or the patient develops a significant disability. So that is the time when the disease-modifying therapies have to be given. That is when they are the most effective. There are many ways in which you can give DMTs. The usual way we used to give was, we give a moderately active or a platform therapy first. And if the patient has ongoing problems while on this therapy, you escalate to a stronger therapy, like monoclonal antibody. There's another way that you can straight away start with a highly active therapy like a natalizumab, fingolimod, retoxamab, etc. Or you can straight away go for immune reconstitution therapy. Now, we have the recent data which shows that it is far better to start a patient on a stronger immunotherapy, highly active therapy quite early in the disease rather than do the escalation therapy as was previously practiced. But then we don't often do like that all the time, because we have a trade-off between the efficacy as well as the safety. So when you see the safety issues, we find that the glatiramer, terraflonamide, interferons are all extremely safe, whereas the stronger medicines have a higher burden of safety risk. So when we choose a DMT for the patient, you have to understand what is the disease activity. Is it a high disease activity or a low disease activity? Whether the patient is likely to develop more of side effects, like those who are already have been exposed to immunosuppressants, older patients. What is the patient's own preference? Would they prefer to have a stronger therapy? Would they prefer to have a lighter therapy? What is their preference for risk? And what is the cost factor? Like how can they afford the therapy or not? And of course, the comorbidities like which can worsen the side effects should also be considered. We should always plan for achieving no clinical or radiological activity, which is known as no evidence of disease activity, but this is practically difficult to attain. So sometimes you may have to compromise there. Whether we'll be able to stop therapy in MS or not is an area where there is active studies ongoing. At present, we understand that it is better to stop therapy when the patient is beyond 45 to 50 years of age, and when there is a chance that the patient when there is a chance that the patient will sustain to have a remission. That is possible if the patient has completely all right for at least 5 years, and when they're older patients or when they have already significant disability and has gone into the secondary progressive phase. Finally, a small note about progressive MS. We know that there is a lot of inflammation in progressive MS as well, but this translates to degeneration because of mitochondrial damage, oxidative problem, and all, which was discussed by Professor Netravathi. But here, the inflammation is completely encased within the MS, and it is not that accessible to the disease-modifying therapies. But recently, we have had 2 drugs which have shown support. Natalizumab has been found to be useful in PPMS, and Siponimod has been useful in SPMS, both of which are not at present available in India. And we also should know that it is all not just DMTs. A lot of lifestyle changes are required to maintain the CNS reserve. The patient should be asked to exercise regularly, have a good anti-inflammatory diet that is more of vegetables, more of probiotic agents, more of fruits. Vitamin D should be adequately corrected. Sleep, stress management, temperature control, as well as much social stimulation as possible. A big part of which is maintained by the patient support groups like Mssi. And finally, we understand that DMTs, although they target specifically relapses, they modify the natural history of MS. It is important to start the treatment early because age is an important factor which determines the DMT efficacy. Thank you.
Thank you very much. When your topic was very large, but I think you covered all of them so beautifully, telling us about the first line, the second line. And I'm sure there are many questions and we'll take them as they come along. But at the moment, we'll go to our third presenter, Dr. Deepak Arjundas, who is a consultant at Mercury Hospital, Chennai, and Vijaya Health Center at Chennai. He's a founder member of the Asian Acute Stroke Panel. And of course, he's an important member of the Indian Academy of Neurology, Indian Epilepsy Association, Neurological Society of India. And he has varied interest, as you can see, treatment of various neurological problems, nerve and muscle, the stroke, epilepsy, vertigo, MS. And he's got multiple publications and research papers in all these areas. In the award section, he's written only one, but I know there are more. Life Achievement Award, Neuro Update 2019. So, Dr. Deepak Arjundas is going to talk to us about MS in India, closer to home. And for a long time, we believe that MS is a disease of the Western world, but we now know there are lots of patients with MS in India and probably increasing. So, in the third lecture, let's come closer to home and request Dr. Deepak Arjundas to tell us about MS in India. Is it different? Is it the same? Is it increasing? Lots of questions. Deepak.
Good afternoon, everybody. Thank you for giving me this opportunity to be with all of you. And so let me talk on this topic of multiple sclerosis in India. As you all know, that this is a disabling disease and it's almost like a tragedy striking the family. Multiple sclerosis initially we thought was a Western world disease and well known in the West since its description by Charcot in 1868. As we were students, we were even wondering whether the disease really even existed in India. We were very happy at that time and said people had no MS, and up to a point, I remember people saying that there were no brain tumors in India because people had not been diagnosed with brain tumors or multiple sclerosis. In India, the disease came to recognize in the 60s when the physicians who received training in neurology in the West returned to India. The first physicians who described the manifestation of MS in India were Baldev Singh, Bharuch Shah, Ramurthy. Some of them were neurosurgeons, but they received adequate training in neurology. And when they came back to our institute, they used to do neurology also as they used to take DM neurology students and teach them neurology. Then two key papers came out supporting the occurrence of MS in India in the 1970s. The first was by N.T. Matthew, K.V. Mathai, and Abraham, who told about the incidence and pattern of demyelinating disease in India, and it was published and well accepted in the Neuroscience Journal in 1971. The next journal was a profile of MS in Bombay region on the basis of critical clinical appraisal by Dr. B.S. Singhal and Dr. Wadia. The prevalence of MS in India, hospital data in 1970s was 0.17 to 1.3 per 1 lakh population. Dr. Barucha and Dr. Wadia had done work on a group of subsect of population of the Parsis, a small group of people in India, and there he found out that the prevalence was 21 per 1 lakh. And this was published in an article and reviewed by the and also Indian Academy of Neurology. Next, what are the clinical characteristics as reported by Dr. Singhal and his team? He found that the mean age of onset was 26 to 30 years. This means catastrophic. Catastrophic in the sense that patients who came to the hospital were young engineers, doctors, IT staff who had just worked hard, worked abroad, come back, and came with some difficulty after they entered their job. More were women than men, and he also found out at that time the opticospinal form was more frequent, wherein visual symptoms and mobility symptoms were present in this group of patients. A higher incidence of optic nerve involvement, both at the onset and the duration of the course of MS, has been noted till date. More frequent occurrence of painful tonic spasms are seen in a group of patients, and at that time there was a low yield of oligoclonal bands. That was due to the technical problem. Later on, we have sent our people from India to do the oligoclonal band technique properly, and now our yield is quite good. What about the 1970s till now? First we said no MS, then we said a little MS, then now what happened? In 1970s, it was 1.3 per 1 lakh in the 70s. And the shift from low to moderate has come from up to 8 per 1 lakh in 2014. Look at this MS atlas in 2008. Look at us, blue color, down India, we were 0 to 5. We were in the low prevalence group. Then what happened? In 2013, we found MS is being increasing diagnosed in India. This is due to more doctors, more technology, more MRI scans, more awareness among the doctors, caregivers, friends of caregivers, and patients themselves. What about MS in India now? I told you now, we have an MRI available in all towns. Many smaller towns, all big cities have got MRI. 1.5 Tesla MRI is routinely done for our patients, and 3 Tesla MRI is available in a few places. There is an increased awareness of all the public. Significant increase in the number of neurologists in the country When we started, there were 700, now we have more than 4,000 neurologists, and more of them have taken more active training to learn to diagnose MS. This helps us to make an early and a precise diagnosis. Different types of MS has been stated by our earlier speakers, all that have been present and have been diagnosed easily. Also, we have become now a location for participation in international clinical trials, and thereby we are bringing up a window to the world that MS exists in India. More and more data is being available and published from India. We had the next please. One was the prevalence on patterns of demyelinating disease, published by Lekha Pandit, who does a lot of work on MS. She does only MS work, and her love is on NMO antibodies. The next is by the Bhatia team from the All India Institute of Medical Sciences, who gave their experience on the different types of MS. The next publication was the European multiple sclerosis variants in South Asian population by a group of people from here. Next, we had the genetics and the epidemiology. You can see our papers are getting more scientific and more close to what is occurring in the West. And this Robert Bhatia had told us about the different genetic aspects that were seen in multiple sclerosis patients. Then Beam Singhal had written an overview of MS in India, and this was well accepted by all the people and gave a boost to the number of patients being diagnosed by MS. Then came another paper by a perspective again by Dr. Beam Singhal, which was published in yet another journal, and he had also there was also a publication about the molecular etiology of this MS in South Indian patients by Diligent Joseph, who had shown that patients in South they had a particular type of susceptibility and a molecular etiology identifying a group of patients who are more susceptible to MS. Lastly, we had in 2015 again Singhal with Advani writing about MS in India and an overview. You can see from this publication that from no MS to so much of MS in India that people now come and say, with blurring of vision, they say, Doctor, do I have MS? They come to the clinic and they want MS as an exclusion from the diagnosis from the illness. Next, the challenge of multiple sclerosis. What happens? How do we evaluate in our country? We know it's a relapsing disease, and that's about 10%. Secondary progression is very common, and 70 to 80%. Then the variable disease occurs by showing the MRI being done periodically. We can see enhancing lesions, and the surprising thing is, in India, in spite of having no treatment, lesions disappear. Many of my patients who do not take treatment for various reasons, either family, social, financial, they don't take treatment. They come year after year to see me, they don't take treatment. The lesions have gone. Few of them come back with a new lesion. And it's quite perplexing how different patients in different geographical areas behave to this particular disease. We know now that from the earlier two talks that MS is the drugs in MS is most effective only in the relapsing type phase of the disease, and the variants responsible to therapies have been reported from different parts of India. To the challenge in India specific is it MS? Do we do DMD and MS therapy in India? Do we do all the patients? Initially, we thought we should not do all patients, only the ones with the severe one we would do them, and the lighter ones we would wait. Then, how do we monitor our treatment? Monitor and treatment is quite difficult in our country, unlike abroad where they have big societies and big funds and big studies which look after the patients. And more than that, how is our treatment failure determined and managed? In our country, a lot has got to be done for this. Everyone comes and says, we did this, we did that, we got good results. So the number of papers on failure and poor management are very few. But it's important to know that MS requires holistic management, symptomatic therapy, and it does require a multidisciplinary approach. Just not a neurologist you need a whole team of people to do it. At this point of time, a small deviation. We must know that there is a disease called NMO. It's a neuromyelitis optica disease due to an NMO spectrum disorder. We must make all our MS colleagues remember that this is a separate entity and you should not push your doctor to diagnose of MS. The doctor knows best for you which is not an MS and which looks like an MS mimic. Because we find many patients, we tell them you do not have MS till they take interferons and come back. Then we tell them, why did you do it? No, they say, no, I read everything in the book. My findings are MS. I decide my treatment. Why we do it? Why we tell all the patients this is that NMO is not a variant of MS and the treatment is totally different. Next, please. The disability attack in MS is is unlike NMO, and it is found that the visual loss which can be prevented, irreversible visual loss and myelitis, and early treatment can be prevented by taking proper treatment in MS. The disease modifying drugs used in MS will worsen an NMO spectrum disorder. Though there may be similarities in the brain imaging, you need to know that the treatment is different and we need to differentiate one from the other. Also, the therapies have gone a long way. Earlier, we used to use ACTH injections and then oral steroids. That time, methylprednisolone was not available in the country. Now we have excellent treatments available. We have methylprednisolone available at a very controlled price. A lot of symptomatic treatments available. A lot of rehabilitation centers available throughout India, especially in the bigger towns. Smaller towns have got less rehabilitation facilities. And earlier to talk to you, the earlier talk, you have seen we have got almost all DMD drugs which are useful for remitting type of multiple sclerosis. And we all know a lot of vitamins and supplementary vitamin D are important in the treatment of multiple sclerosis. We know that the therapy for MS, apart from the interferons and DMD drugs which have been mentioned, for spasticity we have drugs which are easily available like baclofen, cisanidine, tolfenone at a very reasonable price. Then we have MS-related pain being treated by a group of drugs like amitriptyline, carbamazepine, gabapentin, pregabalin, lamotrigine, which is again available throughout and freely available. Fatigue patients with fatigue, amantadine, modafinil is used. Patients who got spinal problem, dalpredine is used. Patients with bladder dysfunction, octreotide and tamsuline, and patients with sexual dysfunction, we have sildenafil. In short, to tell you all that different drugs are available for all the symptoms that are available that may occur in a patient with remitting type of MS. So we are at par with the world for producing all the symptomatic therapies. This slide has been presented earlier showing you from 1993, from interferon to where we have progressed to cladribine. All this have been year by year, we have been having so many new drugs which help our MS patients. As of now, this slide will tell you all the drugs which are available at a very reasonable cost. And as a previous speaker told us, that we prefer to use a drug which is safe. Because if a patient walks in and tells you, we tell him we got MS and we got to use a powerful drug, he may have side effects or do a transplantation and that may not be useful to him or may produce a serious side effect, then it becomes a big issue. The cost becomes an issue. Today in our clinic, no patient goes without the DMD drug. They are so inexpensive now. We let them have a part of it and then we let the MS Society pay for a part of it and we follow them up each month. We give the physiotherapy free of cost and we give the physiotherapy free of cost and we try to bring them into the society. We speak to IT companies to give them a job along with the DMDs. Once we have them to the MS, we try to follow them up in an equal way and try to bring them into the society with others. So the DMDs then were only injectables, poor efficiency and expensive only for the upper class people. We used to import it with the name. You put the name, send it to the drug inspector, then they would give a license and then you could get the drug. But now injectables and orals available. Highly efficacious options are there, and the generics have improved access to more and more patients. All poor patients in the city of Tamil Nadu, the city of Chennai, the state of Tamil Nadu, have access to full therapy either from the government hospital and from the MSS society. Till today, we do not have anyone who is not taking treatment because of the cost. And we've been very fortunate that the MSSI has helped us for this. This is what we do for our patients of MS India. What I do. We are sitting in a hospital. We do the neurology part of it. We have consultator with partners for ophthalmology. We have a psychiatrist, a speech therapist, physiotherapist, neurologist, and a psychologist. And most of the patients run through this full team. Has evolved with better diagnostic criteria, facilities, and awareness. More and more cases are getting diagnosed and treated. Treatment options are now made available and affordable by launch of DMTs by Indian companies. No single patient goes untreated, and there is still need for MS clinic, patient support, and rehabilitation. I thank you for your patient listening.
Thank you very much, Dr. Deepak. I think you did justice to your topic, MS in India, how we moved from no MS to where we stand today. So, all of you have heard the 3 lectures now. Now, Anjali was supposed to be here for the World MS Day, but for some reason she cannot. So, let me make some comments about the importance of the World MS Day. Oh, she's there. Are you going to speak, Anjali?
Yes, sir.
Yeah, do go.
Definitely. I would love to because, yeah. So, hello, everybody. Good afternoon. It has been a pleasure listening to all of you. And the last presentation was really, really enlightening. Thank you, sir. So, my name is Anjali Vyas. I'm a person living with multiple sclerosis and also the World MSD representative for the Multiple Sclerosis Society of India. So, I'm going to just brief you about what actually multiple sclerosis, World MSD is all about. So we all know that the World MSD is officially observed on the 30th of May. And you know why? Because it is the MS movement's annual campaign to raise awareness on the condition and to support and connect with all the people living with multiple sclerosis across the globe. It is a day to celebrate the global solidarity and hope for the future. The first World MS Day was initiated by the MS International Federation in 2009 to express the solidarity, begin the global MS movement, and celebrate this entire movement with different themes every year. Since the past 2 years, because of COVID, and also because all of us have been living and connecting virtually, we have been celebrating World MS Day using the theme #MSConnections. This year too, we're following the very same theme, which is called #MSConnections and connecting with people. The MS Connections campaign is all about building community connection, self-connections, and connections to quality care. And that is the very reason as to why we have joined today at this webinar together to learn more about these advancements and more about multiple sclerosis. What can really this MS Connections campaign do? It will help challenging social barriers and the stigma that can leave people affected by MS feeling lonely and isolated. This will help build communities that support and nurture people affected with MS across the globe. It will also promote self-care and healthy living with multiple sclerosis. This will further help us in lobbying decision makers for better services and effective treatment for people with multiple sclerosis. And last but not the least, most importantly, connecting people affected by MS to the MS research. So now that we all know what this entire campaign is all about, I would like all of you all to continue this session and have enlighten all of us on the very global MS movement, what advancements we all are doing, when it comes to medical aspects in MS, and empower all of us and celebrate this World MS Day. Thank you so much. Namaste.
Thank you very much. That was terrific. Your enthusiasm is infectious. I'm sure we'll have a very enthusiastic panel after this. So I think it naturally follows that we now request Dr. Rekha Bhatkande, who's the Director of Shushruja Citizens Cooperative Hospital, Mumbai, President of the Family Welfare Agency at Mumbai, and importantly, Vice President, Multiple Sclerosis Society of India, and Vice President of the Federation of Senior Citizens of Mumbai. So you can see that she works in various planes, even though she's a gastroenterologist by training and helps people in that respect as well. She's going to tell us about the MS Society of India. So let me welcome Dr. Bhatkande. Please tell us about the MS Society of India, which I know is such a vibrant society. Dr.
Thank you, sir. Thank you for allowing us to showcase the MSSI in the webinar today. And of course, Anjali, our person with MS, is so positive. We know that's what we're striving to do for all our persons with MS. MSSI, greetings from MSSI to everybody on the panel today, and also to everyone listening in. The Multiple Sclerosis Society of India, we are a support group. And this group was established by Sheila Chitnis and her co-founders in Mumbai way back in 1985. And since then, MSSI has grown. We now have 9 chapters throughout India. And these chapters are manned by volunteers, caregivers, and persons with MS themselves. So what does MSSI do? Before answering that, I would like to tell you, because there are many doctors listening in today, I'd like to tell you what it is that we definitely do not do. We do not interfere with, change, or stop the treatment recommended by the neurologist or the primary treating doctor. We don't do that. As a support group, we offer help in neurorehabilitation of the MSPs with physiotherapy, either at the center or home physiotherapy. Counseling and dietary advice is also given. We give physical aids like walkers and wheelchairs and other items to promote independence in our patients. We help MSPs get their medicines whenever possible, free of cost, and we hold free health checkup camps for them every year. We support the education of young MSPs or help the children of the MSPs with educational grants. We encourage our MSPs to work as seamlessly as possible in their offices by connecting with their employers or from home. And for that, we supply computers, sewing machines, and other items of trade that they can use to work from home. We encourage leisure group activities like picnics and movies and cultural programs because this is one of the principles of one of the 7 principles of management of MS patients by in enhancing their quality of care. We get disability certificates for our MSPs, either in person or online, and we conduct many awareness programs throughout India. Now, we need the help of the medical fraternity to help us find the prevalence of MS in India. Dr. Deepak Arjundas has already told us that, how the prevalence has apparently shifted from 1.3 to almost 5 to 20 per lakh. In 2013, we were declared a rare disease. In the 2019 list of rare diseases, MS is not there. But what happens is that all our advocacy activities depend on the actual numbers of MSPs. You know, when we talk to authorities, they want to know what is the number of MSPs in India. So that's really very important. And for that, MSSI had launched a crowdsourced MS map in India to get prevalence right. So do visit our website and check out all our advocacy campaigns, and also, just see what we have been doing on this MS map. Now we have one of the things that we are very keen to look out for, people who we want to look out for, are our caregivers. So we have launched a caregiver guide, and of course the awareness brochures are in various regional languages. 9 chapters. Now, I would like to appeal to all the doctors to kindly request your patients of MS to register with us, because we really do care, and for personal quality of life. Thank you.
Thank you, Dr. Balkande. Thank you very much. Of course, the MSSI is doing a lot of good work, and they form a bridge between the physicians and the patients. And it is so important, particularly for patients. You know, often consultants are busy and they can't give a lot of time. So people tell me that their visits to the MSSI were very useful because they found friendly people there, and they could sort of talk to them about various things that they wouldn't talk to us in the consulting group. So please do keep up the good work. And thank you very much for telling us about it. Now let's go to the last part of this program, which is a panel discussion. All our 3 experts who gave lectures will participate, and we've got one more 4th expert, Dr. Gunjan Kumar. He's a young doctor, assistant professor in neurology at Patna. And his areas of interest are, again, as you see, varied. Headaches, migraine, trigeminal neuralgia, epilepsy, seizures, myasthenia, movement disorders. So he's practically doing everything. He's got an International Headache Society scholarship for training in headache. And the MSSI people tell me that he does a lot of work for the MS Society. So welcome, Dr. Gunjan, to the panel. And maybe what we can do is, some of the questions that have come to me, I will start with them. Maybe we could sort of address them to one expert, but please feel free to sort of join and tell about it. Deepak, are you there, or did you have to leave? Deepak? Deepak, are you there?
I can't see his.
I can't see him, so probably he's left. So that's fine. So whoever wants to take the question and add additionally, please do. So let's start with some of the early questions. So youngest is the best. So Gunjan, the first question comes to you. You know, somebody has asked a question that there is a relapsing remitting type, there is a progressive type, and primary progressive type. So what are the percentages of these that you see in practice? Which are more common, and generally how does the disease behave?
So typically what we get is like the ones are the relapsing remitting types that are the most common which come to us. Problem is that in our state, still it's like at the cusp of the change. We have a lot of patients here who are still underdiagnosed. And the theory is that most of the physicians and all, they are the first point of contact. So for them, unless it is a relapsing remitting case, they don't refer to us. That is one problem. So usually what we are saying is the relapsing remitting cases. And most of the patients, when they get the MRI done also, is just a plain MRI without the spinal cord. And apart from that, surprisingly, even for optic neuritis and other things, the CT scan is being done. So the relapsing remitting, that is almost all the cases are there. Apart from that, we see some primary progressive, which takes some time to diagnose. These are the patients which come for regular follow-up, and over the time of 2 to 3 years, this is the time which we diagnose. And there are a few cases of secondary progressive, but almost like 80-90% cases, what we see are the relapsing remitting type only, sir. That is
Right. So you're making an important point that other cases which are primary progressive may be difficult to pick up for the physicians, and therefore difficult to, they're not referred. And that sort of brings us to another question that has been asked by another doctor. Do you think that the primary progressive MS is underdiagnosed? Does Dr. Shruti or Dr. Netra want to take it up? Is it underdiagnosed? You see patients who come to big institutes and are nicely worked up. What do you think was the diagnosis with which they are sent, and the final diagnosis that you make in the institute? Do you think they're underdiagnosed?
I would say that it is both underdiagnosed and sometimes it is overdiagnosed. Why I would say that is, I have seen that the neurologists who diagnose, who are trying to see MS, they sometimes they don't recognize the opportunities for actually treating the patient. They do not pick up the intermittent improvement the patient has in between, and they miss that the patient has been relapsing. And that, I think, sometimes just they label things as PPMS when a course of IV methylprednisolone should be given, and we should see if there is a real improvement about to come. But then there are also cases where they just diagnose MS and sometimes institute drugs like Natalizumab, or they look like highly active agents but are really ineffective against progressive MS. So if we get the idea that this is going to be more of a progressive phenomenology, it is better to start with a drug like Retoxamab, which may have some effect. We do not know that it has any effect, but it has the studies have shown that the confidence intervals are at least parallel to what is seen with Ocrelizumab. We may have a chance that it might improve. We do not know that for sure yet, but at least that is a better choice of medicine than a medicine which may not act at all in the progressive MS. But I do understand the question in the sense that in the periphery, this is one of the underdiagnosed situations, because the presentation is not something which you expect in MS. They just present with progressive spasticity or something, and they are often diagnosed as vitamin deficiencies or CV junction anomalies, some genetic diseases, etc. So I understand the question, but there are opportunities of treatment which may be missed.
Correct. So like what you pointed out, sometimes we miss the opportunity of treatment, sometimes we overdiagnose other conditions. So you see both sides as from your angle at the institute. Dr. Netravathi, you want to make any comments?
I agree with Dr. Shruti. And most of the time, once a person has been diagnosed with multiple sclerosis, it's like a fancy diagnosis. A patient want the diagnosis. So if they come to us and we tell it is not MS, they won't take it nicely. And most of the time, it becomes very difficult to convince them that it is not MS. That I find it more difficult than trying to diagnose multiple sclerosis. The mimics which are there are actually being diagnosed as MS, and sometimes many other demyelinating disorders which are there.
Yeah.
And of course, this question on primary progressive MS, yes, I think sometimes when it starts, especially as Shruti pointed out, only starting with spasticity, it can be mistaken for either spondylitic changes or because of hereditary degenerative changes. So both the spectrums are there. So it is difficult.
Yeah, correct. But I think all of you made this very important point that there should be awareness amongst physicians, the general practitioners and the patients, that MS is not just relapsing remitting. It can also be a progressive condition, and therefore one should be open to that diagnosis as well. The next question in the diagnosis line is, how difficult do you find?
And the patient comes to us with the optic neuritis. If the severity is very less, and if the patient has improved even without medication, maybe it goes in favor of MS. Whereas severe form of optic neuritis where it's almost gone to blindness goes in favor of NMO. MOG, of course, it's a spectrum where it can just go in between, but again, it is also very severe form. Sometimes it can be very steroid responsive. Just on high MG of Isolin, also they respond very well. So I think the clinical scenario is very much important when we take the history to diagnose all these three things. And when we are seeing the patient who has come to us first time, let us see the patient clinically, see and make a diagnosis before we depend on the MRI or the antibody testing. I think that should be the stepwise progression which should happen. Yes. Then I don't think we'll err in the making the diagnosis. But of course, there are some gray areas which can be there. But still, I think clinically we'll be able to make out.
So for NMO, bilateral optic neuritis, severe optic neuritis, severe deficit, it doesn't improve, and lesions in the cord and the optic nerves, that sort of sets them apart. MOG is the new one, which is slowly sort of gaining ground. So any comments you want to make, Dr. Suruthi or Dr. Kunjan or Dr. Netra on MOG, the tips for physicians? When should they say, oh, this could be MOG?
MOG, sir, radiologically, actually we have started in the suspected patients of MOG, we have started doing diffusion of the optic nerve also. So that is one, this one MRI which has been beneficial, and apart from that, the optic nerve involvement, the area which is involved, that is quite there. And if there's some MRI features are there, if there's like conus involvement is there, that is more typical of MOG. So these are some of the MRI points. Apart from that, madam has said that clinically, the first diagnosis should be more of a clinical diagnosis, supported by the radiological and then the investigations. So there are some of the MRI findings, and apart from this is something which I just wanted to point out, that these are some of the points in MOG which we are using to pick it up.
So for physicians, can we just say when to suspect MOG?
Like clinically, madam has already pointed out, like optic neuritis is there. That is one thing. Apart from that, in children, ADEM can also be one presenting feature of MOG. And especially if in NMO, the myelitis and all is more severe as compared to the multiple sclerosis. So these are some of the points which for the general physicians, which they can find.
I think even though the conus lesions initially were stressed upon, I think as the series are getting larger, even dorsal, cervical, doesn't seem to be that much. Right? What do you both think?
Yes. I think, sir, MOG is, I think it's more easier to differentiate between MS and NMO. We know very well. MOG is something which either goes towards NMO or just goes in between both of these. So there, I think a lot of clinical judgment would be required. And I think we should, for a physician who sees, if in a child he sees a patient who after a febrile illness or after a vaccine has developed a neurological disturbances, which looks like demyelination, like Adam-like picture, I think that they have to test for MOG in a child. In an adult, if they have recurrent optic neuritis and MRI brain is normal, because most of the time outside they wouldn't have done the optic nerves, like what Dr. Gunjan specified about doing the optic nerve imaging. So optic neuritis is there, MRI brain is normal, I think then optic nerve has to be screened. And that will give a clue whether it is NMO spectrum or whether it is MOG. And coming to the other part, like in a child itself, it also can be like leukodystrophy-like pattern. So if they find that even a short course, just 1 day of steroid also, if the patient has improved, then see even MS, NMO, they do improve, but it is not that very immediate improvement in MOG. So how fast they improve, they also worsen on decreasing the steroid. I think these are the few clinical clues towards MOG. And as you pointed out, it is not just conus. Any part of the myelin can be involved.
I think before we leave this area of questions that have come, one doctor wants to know about progressive relapsing form of MS. So any comments on that? I mean, that's the most uncommon as we know. So any comments on that? First progressive and then up and down.
So the progressive relapsing form, when it was described, was a person who had a progressive phenotype. And on top of that, the patient has intermittent attacks, which then comes back to partially to baseline. But as we know right now that this is a little bit of an artificial separation. This relapsing form and progressive form. These are just different manifestations of the same disease. So I think in a clinical perspective, we are more and more understanding this part. We just need to understand, does the patient have relapses? And is there an ongoing progression without relapses? So I think the management protocol would depend upon what is that status of the patient. So we do not need to label it as RRMS or PPMS or anything. We just need to see that is this MS? And if it is MS, does it have relapses? Is there any recovery? And is there a worsening condition on the background?
Correct.
So you can mix and match into any type. You can call it a relapsing remitting MS, secondary progressive MS with relapses, without relapses, any mix and match you want.
Correct. It's more for people who are tabulating them for purposes of follow-up and work. Yeah.
I think primarily created for clinical homogeneities in RCTs. This was the primary purpose of creating that.
Absolutely. Yeah. So that they can be tracked better. Yeah. Now, what is another question is, what are the common differential diagnoses that we see in clinical practice, which are missed for multiple sclerosis? And I think that's an important question. So inputs from all three of you. What do you see in your practice, which either is called MS but is not MS, or vice versa?
I think we already discussed on the NMO and the MOG spectrum, which can mimic multiple sclerosis. So apart from that, I think migraine, headache is one of the most common disorder where MS is diagnosed. So a patient would have had a bad headache or chronic headache, and they will have some white matter lesions. Actually, we call them as UBOs. But these UBOs can be misinterpreted as demyelinating lesions and multiple sclerosis. And they are the most difficult people because they do not want the migraine or headache diagnosis. They want MS diagnosis. And I am the worst doctor who has diagnosed it as migraine and not MS. So I think this is the worst differential diagnosis which will be there. Then the others would be many other vasculitic changes which can be there. Secondary demyelination, which we call. So it could be either because of the APLA spectrum or a SLE associated demyelination. And now we also need to know that a lot of medications also can cause demyelination. COVID, of course, has shown us that COVID can cause. But apart from that, many medications, especially who are on chemotherapeutic agents, so many of these and rheumatological agents which are there, these are all can further eventually develop demyelinating episodes. So we also should remember these things which can be limiting.
Absolutely. And some tumors, sometimes the lymphoma is there.
Yes.
Dr. Sruti, your comments on that, and then Gunjan, because I think this is important differential diagnosis. Yeah.
So mimics of MS are as bad as neurology. So the thing is, clinically, what we would see is migraine, I fully agree. But what we really have difficulty in differentiating is vascular diseases. So small vessel vascular diseases, vasculitis, APLA syndrome, connective tissue diseases. These are the most important ones, which when MRI-wise may mimic an MS. So unless we do a proper systemic evaluation, we will miss this. Then, of course, as Dr. Netravathi was telling, we have to look for secondary causes of demyelination, like chemotherapy-induced demyelination, nutritional causes. We have had vitamin B12 deficiency, which has mimicked an MS. They have shown discrete as well as confluent hyperintensities. Another area which is sometimes difficult is a person with leukodystrophy, adult onset leukodystrophies. So they may have discrete hyperintensity, some rare forms such as ALSP and all. They can have yes, they can specific hyperintensities only in CST, corticospinal tract. That is something else we need to differentiate, particularly from PPMS.
Yeah. So I think we touched upon parts of diagnosis, parts of differential diagnosis. Now let's go to the area where there are a lot of questions. This concept, very nicely it was described that it's initially inflammation and then degeneration. So the approach is moving more and more towards hit early and hit hard. And then when you're early, you really don't know what's the behavior of the disease. So you are in a little bit of difficulty when to hit hard, when not to hit hard. And I think it was very nicely explained that you have to talk to the family and You have to see high lesion load versus low lesion load, and then try and make up your mind which one. But generally, again, for general physicians who have tuned in and for general practitioners, where will you say, okay, this patient I have to hit hard at the word go? What would you say are the markers?
I think we have a lot of poor prognostic factors which we need to remember when we see people with MS. One is the gender, men especially, and then if they have a brainstem syndrome. So I'm talking first clinically. So first is the gender, and then brainstem syndrome, cerebellar, which has not improved initially on medications, and persistent bladder dysfunction, which is there. So all these are clinical markers which tells us that they are not doing good. But after that, it's always the MRI. If we see MRI shows a high lesion load or a coalescing lesion load, but patient has completely improved 100%. So I think I would give that time more weightage on the MRI than the clinical, because we see this clinical radiological paradox a lot, especially in highly active MS in the initial part, when they would have just come with a transient optic neuritis, but you see MRI shows a very high lesion load and coalescing lesions. So this is one place where we need to hit them hard. So take the clinical as well as the radiological, where it shows that there is a high lesion load and atrophy setting in very early into the illness, suggests that they are already going into the degenerative form. So these are the things which we need to look into it and hit them hard. So we no more follow that pyramid where we start with first line, second line. Now it is always start off with which is the best drug. So as you said, the two taglines which we need to remember is hit hard, hit early, and hit with the correct DMA. I think that is also one of the requirement which is there. So first, correct DMA which has to be chosen.
Very well said. I think clinical and radiological. And radiology probably has a lot of meat now in the decision making. And there are patients, like was mentioned, who are clinically okay, but the MRIs look terrible. It is much better to sort of go and hit them harder. Dr. Shruti and then Dr. Gunjan for your comments on this, because this is an important area. And I think we are moving towards that paradigm slowly and steadily.
I fully agree with Dr. Netravathi. Very little to add on there. The idea is to have a very, very low threshold for giving a highly active therapy. Apart from what doctor told, especially it is male and ataxia, that is the main factors which indicate about prognosis. And in addition to what was told in MRI, infratentorial lesions and morospinal cord lesions, there is a high chance of patient going into progression. So any other factor I think are of less important. So if we have at least two of these poor prognostic factors, it is much better to go into a highly active therapy as early as possible.
Gunjan, anything?
So there are patients who come to us like they have one attack, then they go to another doctor, then they come. So there are patients like within 1 year, they have 2 to 3 relapses. So these are some of the patients who are and not on any treatment. So I would think these are some of the candidates for whom we have to hit hard, like because they are having quite frequent relapses with quite a few like burdens on the MRI. So these are some of the patients like I would like to start. But again, the problem is that most of them would like to prefer the oral ones. Again, we have the oral age, the pregnancy, and there are multiple factors are there. So it has to be individualized again. But these are the patients who have like quite frequent relapses. So these are some of the ones which are.
So tailored therapy for each person. Yeah. Now, most of our patients now, because the treatments have come within their range financially, and there is also support from various things. Most of our patients are now on some medication or the other as soon as the MS is diagnosed. And for those who are doing well, a question comes up, when do you stop the treatment? And more people are asking this question in India. I'm okay for 4 years, I'm okay for 5 years now. Doctor, what do you think I should do? So what are the guidelines about when to stop the medication? Of course, it is individualized, but broad guidelines. Yeah.
I think this is a most difficult question because even when patients ask us, it becomes very difficult to tell them that this may be for a longer time, though they are doing well, and they're doing well because of the medications. So the moment the medication's effect is gone away, they may relapse, they may not relapse. Which spectrum they will go, it will be difficult to tell. So whether they want to take the risk that I think we should have a proper discussion with the patient before trying to stop. Otherwise, if they're planning for pregnancy, I think this is a time, the transient, we can stop the medications for a while. Otherwise, after 50, 55 years of age, because it is known that eventually after 50 years of age, it starts declining. And by 60 almost, the spectrum, if they have not had relapses in the last 5 years, the chances of recurrence may not be there. But again, this is not foolproof 100%. Because till now, though I had told like this to many people, we've seen that they can come back with relapse again.
Yeah, that's this unpredictability of it.
So we need to talk to them and then discuss with them, I think.
Longer duration of quiescence, more age of the patient, slightly tilts it in favor of a lesser medication, but each case different. Dr. Suti, you want to make comment?
Yes, these are the guidelines wise, you are supposed to stop only when you're beyond 60 years and in the SPMS with no relapses for at least 2 years. So that is a very morbid way of looking at it. I think that we may be able to stop in a few more patients at least. So the age as well as the clinical stability for at least 5 years would be the two main factors. I think we should have a dialogue with the patient, and certain patients, especially male patients who may have a rapid worsening in case they have more attacks, we should probably caution them against stopping medicines. So one more attack may just tilt the balance to one direction.
It's a very interesting question. At one end, we call all these agents that we have as disease-modifying therapies. And then at another end, we're talking of NEDA. What's happening? So comments on that.
So my comment is that disease-modifying only means that it changes the course of the disease process. So what we are saying they do is that they change the natural history of MS. Or that is my understanding of it. But NEDA is actually the target which we plan to achieve. So although they modify it, they don't stop it or they don't cure it.
Right.
They just tilt it up or down. I'm sorry,
Right.
in a positive
the
direction.
Person has exactly pointed this out, that while your treatments only change the course of the disease a little bit, are we okay saying that NEDA is our aim?
It is
that's what has been asked.
Yeah, it is a good question. The achievement of NEDA is so rare.
NEDA is such a huge expectation. I think the drugs that way are milder. So I think we all probably agree that there's a little disparity in these two. But nothing wrong in saying that should be the aim. And maybe better DMTs will allow us to reach that point. There's another half of the question where it's not clear to me, so I will leave
the
that.
IRTs, the immune replacement therapies like Alemtuzumab, Cladribine, stem cell, I think these three come closer in achieving
to the
NEDA.
achieving.
But none of them will be able to get NEDA.
Yeah. Then there is this question, the current question on gut microbiome and everything, including MS. So any comments on that? I know it's a very difficult subject, an evolving subject, but a lot of work already is there. So to a patient of MS, because there are a lot of patients also listening to us, what would you advise about the gut microbiome, and is there any enough evidence now to say, okay, you please do this in addition to all the DMTs that you're taking?
Gut microbiome. So we do know that this is somehow related to MS, particularly from mice studies. The experimental model of MS in mice, this does not happen if the mice is germ-free. So if you have a mice who's microbiota, they do not seem to get MS plots or get very few MS plots. So it does play a role, it seems. In humans, unfortunately, the data is so varied that we do not have any consensus regarding what. So we just know that compared to normal gut microbiota, the MS person's gut microbiota is different in its constitution. And we have in some study, the studies are so varied in its the results. And it has also been shown that therapy seems to change the constitution of this gut microbiota. So what to give in in the diet advice? It is everywhere. So many articles saying don't take milk, don't take gluten containing food. But I think that what has been repeatedly understood is that take as many antioxidant food as possible. Tilt the balance towards a positive immune response. So more of vegetables, fruits, yogurt, and food stuff which are antioxidant, less of oxidant food. This is what I think is even remotely supported by evidence.
And the enema as a treatment
I do not have any.
is still probably maturing, but that's certainly one thing that keeps coming up. Comments from the other experts?
I think what Shruti mentioned is the same thing about this enema part, especially when many of them try to use other indigenous medications, especially Ayurveda therapy. I think there this enema does have play a role. So in whenever they're trying to start a therapy, I don't know, there are a few studies which are going on, even one in Eminence it's going on. So really do not know the efficacy, how much it is, because these are all just under the research which is there. So nothing, no guidelines, nothing has come. These are all under research, but whatever benefits, there is nothing wrong in it.
It's more a flow of thoughts at the moment in so many neurological diseases, and MS also is one of them. So at the moment, very evolving. So probably can't advise directly to patients on that. So Dr. Bhatkande has appeared. That means our time is up. So if the experts want to take one question or two, which they think everybody should know, please do go ahead, and then we hand over to Dr. Bhatkande.
So if you could sum it up, maybe perhaps.
Yeah, very briefly I will. I think we had firstly we had a lovely session, and I think all the speakers did justice to their topics. We covered the pathophysiological aspects, we covered the new disease-modifying therapy, and also covered how MS is in India. And then we took up in the question and answer session some parts related to the diagnosis, differential diagnosis, planning of the treatment, and some of the upcoming things like gut microbiome. There was another question on the stem cell, but I think that was already answered in the lecture. There is not the stem cell as we understand the stem cell therapy in this disease. So I think we've had a very useful session, but I think still a lot has to be done in terms of awareness of MS within general practitioners, even physicians, so that they send it to neurologists or diagnose it themselves. And then now that treatments have become much widely available, there's a lot of scope for our patients to be on the good medication that they should be on, and their diseases will probably turn favorably. So, yeah, so on that note, can I hand it over to you, Dr. Bhatkande?
So may I ask you, what about research in
please
MS?
ask a simple question.
No, research in MS, sir. Is there any way forward for doing research in MS?
I think we have two experts here in big institutes in the country, so
yeah,
so maybe they can. Of course, we are positive about that. But you want to tell a little?
I think a lot of research is going in trying to identify a cure. So if you see the spectrum, like what Shruti showed, the rainfall of disease-modifying agents which have come. So there are many medications which they're trying to see where we can have a cure for it than just trying to control the illness. I think the research is going on in that area more.
Yeah.
Because it is mainly, maybe even has a financial impact also. Apart from that, I think the newer things which are going on is trying to see whether underlying pathophysiology, what is there, especially the mitochondrial aspect, which I pointed it out, and the gut microbiome, which Shruti spoke about. I think there, the fecal transplantation, which can be used. I think these are the areas which I'm aware where the research is going on mainly at this point of time. Shruti, you want to add anything?
No, I think that registry has been started.
Dr. Bhatkande, I'll make one general comment on this. Yeah. Still, the number of neurologists in India is very small. And most of them, their hands are full doing the standard neurology of strokes and epilepsy and what have you. So people focusing on multiple sclerosis are very few. And MS not being to the tune of stroke and epilepsy in commonness, the research funds directed to MS will also become less. So I think this is where the MSSI and advocacy comes in, that you have to make the authorities aware that the research funds have to be shifted to institutions that are working on MS. So I think it's still very early time and very nascent sort of stage.
No, I brought this up because recently I attended the MS International Federation, meet, and there they were positively looking at, supporting research in MS. So, maybe if you'll come up with it, maybe the funders could also.
I mean, just a very broad comment that if we really want to look at it, we should have a group of individuals who are interested in it, line out areas who wants to do what, and do complementary work throughout the country. I mean, it's an idealistic view, but I think that's the way forward.
Thank you, sir. If I may do the Thanksgiving now. Okay. So I thank Dr. Khadilkar, who actually has been a mentor to the MSSI Mumbai chapter for so many years. And he's also on the Scientific Council of MSSI. So thank you, sir, for you're extremely busy, but I know, and thank you for conducting this webinar for us. Thank you, Dr. Netravathi. I mean, your professorship, the way you told us about the changes that take place in white matter, gray matter, the immune patterns of MS. I mean, there is no question about it. You really, in fact, there were some comments, thank you for enhancing our knowledge. Dr. Shruti, I mean, I think in the simplest way possible, you have actually taken us through the entire gamut of drugs that are available, that can be used, and that should be used with caution. Thank you so much for that. I think that is wonderful. Dr. Deepak Arjundas, I think he is already left, but I must thank him for taking time. I think he was talking to us from an airport, if I'm not mistaken. So I think that's wonderful. And in the simplest way possible, he gave us the story of MS, the timeline of MS in India. And that was really wonderful. Thank you, Gunjan Kumar. He is one of the most popular neurologists I know, where MSSI is concerned. He's a go-to neurologist. So thank you for joining us, Gunjan, and taking part in the panel discussion. And I would say that I must thank the Medisage for being a part of, for doing all the IT tech support that they gave us. I would like to thank that is Shraddha and her entire team. I would like to thank our tech team who, were building up towards this webinar. So that is Javed and Kritika, Gita, Ritu, and all the chapters, the teams in the various chapters. And of course, I would like to thank Sanofi for having hosted 4 webinars. They insisted, and they were doing it to increase the awareness of MS in India. So I would like to thank them for it. And of course, I cannot not mention Sheila Chitnis. In fact, today there was some, I think, she got to know about Dr. Arjundas may not be able to join in, and she was so, caught up in that. And I said, Sheila, Dr. Satish Khadilkar will handle it all. So I must thank Sheila for being so involved and being such an inspiration to everybody in the MSSI. Thank you, everyone.
Thank you very much, Rekha. And thank you all the doctors. Really, it was wonderful session. Thank
Oh,
you.
I must say thank you to Sheila. I must thank Anjali. It was such a wonderful thing
Yes,
to
yes,
have her.
Yes. Good
Oh,
to join,
Anjali,
good
yeah,
to
that's
join.
great.
Surely.
She's so positive. Yes. Thank you, Anjali, for joining us.
Always a pleasure. Thanks a lot. Thanks a lot for this opportunity.
You are always wonderful. Beautiful girl representing MSSI and MS on the MSI. Yes.
Ma'am, all of us are beautiful. I don't know why, ma'am. One thing that I really want to ask every doctor out here, please tell me, has MS anything to do with the age also? Because I've seen that every person with MS looks younger than their age. Everyone that I've met. And I actually have asked this question to my neurologist also. Is there any scientific study that says that, people with MS look younger than their age? If so, then please tell us. If it happens,
you are looking younger than your age, huh? Anjali, you are good.
No,
we're
but
very,
that should. Yes,
we're very happy that they do.
Actually, because one of my friends used to tell that you come to the ward and find the most beautiful girl there, she would have the diagnosis of MS.
Oh, wow.
This was noted by one of my colleagues.
Yeah, we actually do have that.
I think it is not
We actually have people like that.
really to see somebody being so positive, especially when it's some neurological problem. As they walk in, I think it is common. Yes, Anjali?
Huh?
As they walk in our room, seeing a specific person having a neurological problem, always
Right.
MS.
Right. Absolutely. I have seen. Actually, I have. And I think everybody has inspired me ever since I've joined MS Society. These people keep me going and, actually let me push my boundaries. Sheila Mama has been the first inspiration for me because I really find a motherly image in her and everybody ever since. I feel MS is a blessing in disguise for me. I truly feel. Had MS not happened to me, I don't think I would have been even speaking on this platform and speaking to all of you people. I mean, I'm really, really blessed. I feel so happy. And also my parents. So thanks so much. Thank you.
Yes, Anjali, you are doing really great job for MSSI. Thank you so much.